Thanks, Mike. Hi, everyone. Again, my name is Megan Smith. I'm here tonight to speak to you all about preparing for work in hot environments and understanding heat-related emergencies. As Mike said, I do work at Grand Canyon National Park. I am the Preventive Search and Rescue Coordinator, paramedic and rescue technician. But a quick disclaimer, while we are subject matter experts here at Grand Canyon on heat illness and helping patients in the austere environment who are suffering from heat illness, we are not the final authority. This presentation aims to give you the very basics in understanding heat-related emergencies and preparing yourself for the hot environment. A quick thank you to Mike St. John. It's a very big honor to speak to you all tonight. I'm part of the Mountain Rescue Association. I've been to your conferences before and feel very honored to be with you. Thank you to Dr. Tom Myers. He's one of our medical advisors here at Grand Canyon National Park. He is a clinician and practicing physician in the Grand Canyon Clinic and co-author of Death in the Canyon. And Miss Anna Marini, who is the Preventive Search and Rescue Supervisor Coordinator at Joshua Tree National Park, who also consulted and helped put this presentation together. Our objectives tonight are aiming to give you the functional tools you need to keep yourself and your teammates prepared and safe for hot environments. You'll also hopefully learn to identify where on the spectrum of heat illness, because it is a spectrum, your search subjects may be. Let's get started. We have to talk right away about the environment, the ever-changing environment with climate change. The bold print there you see in the center of the screen, when temperatures reach 95 degrees Fahrenheit at 100% humidity, or 115 degrees Fahrenheit at 50% humidity. So there's variations in there, but that is essentially the end of the spectrum where our body can no longer tolerate or compensate in the hot environment. I work in mostly an arid climate. The monsoon seasons are upon us now and we're getting decent rain for the desert. And we feel the humidity here in a different way than the hot environment. When visitors come to Grand Canyon and they're from a humid environment, they think that it's easy and the heat isn't a factor or a problem. It in fact dries us out quicker. We struggle in different ways, but I'm not an expert in humid climate and I would defer to you all. I know there's folks from across the nation here and you're going to know better than I how to stay safe in the humid climate. For instance, one of the things we talk about here in Grand Canyon is that cotton doesn't kill. As they say, cotton kills. Cotton is actually our friend here in Grand Canyon, and we'll get to that a little bit later when we talk about preparedness. There's a lot more focus happening on climate change and hot environments. This link here shown on the screen leads to an article and discusses just that. The second quote here I found interesting, that the answer goes beyond the temperature you see on the thermometer. It's also about humidity. Research shows the combination of the two can get dangerous faster than scientists previously believed. The index there on the bottom is just to help visualize or show that child care and daycares, particularly ours, do use charts when looking at sending kids out for playtime in cold or hot environments. And they factor that humidity in there. I don't think we're very good at looking at the humidity here in the arid climate and wondering what that will do and the tipping point it will cause for people to struggle and or have more difficult time in the humid environment or hot environment. We usually look just at 95 degrees or above and know that we're going to start to see more SAR events here at Grand Canyon when we hit those thresholds. The UV index is also something that we don't look at enough. The UV index is a universally accepted standard measurement of the strength of the ultraviolet radiation produced by the sun based on specific times a day, particular geographic locations. So if your shadow is longer than you are tall in the early morning or late afternoon, usually safer times of day, when it's directly overhead and more direct, even with cloud cover, you want to look at those UV factors. They're on most of your iPhone apps or smartphone apps, and you can check those pretty easily. All right, let's get right into it. Compliments of Dr. Tom Myers. He's provided a heat triangle, or as we've discussed here at Grand Canyon, and used this for training our rangers for many years. Too little or too much water, and one or the other causes a problem. So as you look here at your screen, on the left side, you run into dehydration, and down the cascade, it will lead to heat stroke, multi-system end organ failure. On the right side, having too much water can lead to hyponatremia, cerebral edema, and brain herniation in the more extreme cases. In the center of the screen are signs and symptoms. So sign being something that you can see or observe, symptom being something that you can feel or someone reports to you. And in the middle, you can see a long list of things that are really just common signs and symptoms that one can feel or experience or observe in the hot climate. We must pause here now and talk about heat stroke. It too is a part of the spectrum. And here at Grand Canyon, we commonly get reports from hikers and visitors that someone is suffering from heat stroke. How do we know if they're in fact suffering from heat stroke? It is a continuum, as I said, and it could be at the far right end of things where it's minor, causing some discomfort and inconvenience, such as heat rash. You can have swollen hands from maybe hiking without poles and having some stasis in there. Heat exhaustion being that kind of center area, all the way up to heat stroke, where you can, again, experience multi-system organ failure and death. Some things leading to or characterized by heat stroke are core temperature of 103 or greater. Depending on what literature you read, the CDC, there's various documentation out there that cite just over 104 of a core temperature and even some of 106. For us here at Grand Canyon and all of our trainings, we're not walking around with a thermometer to take rectal or core temperatures on folks. Our main goal is cooling them off and assessing them and figuring out what the problem is. So we're going to go solely off of mentation, altered mentation. So if they're acting funny in any way, shape, or form, if they've had a brief, repeated, or protracted loss of consciousness, alteration in sweating. Dr. Tom Myers teaches our ranger staff that in 50% of cases of heat stroke, qualifying as heat stroke, 50% can still show sweating. They'll have clammy skin or moist skin. So hot and dry is certainly concerning. If you put your hand on a patient or one of your peers and notice that their skin is hot and dry to the touch, that is alarming and concerning. You do want to cool those people immediately, rapidly. Nausea and vomiting, flushed skin, rapid breathing, rapid heart rate or racing heart rate, and headache, all characterized within that spectrum there. We're going to talk a little bit more about these signs and symptoms. We're going to pause here, though, or take a little detour and talk about hyponatremia, that other side of the spectrum that I talked about. Exercise-associated hyponatremia is what we deal with here at Grand Canyon. Anybody that is a patient that has a history of protracted or chronic deficits in their electrolytes, could be a cancer patient, it could be a renal patient, it could be someone with extensive cardiac history, congestive heart failures, somebody that's anorexic or bulimic. Those kind of patients we would expect them to have an electrolyte derangement. Anybody in their history that is not eating well or taking in food well, somebody with a feeding tube or a PEG tube, we want to be cautious with them as well. So our treatment protocols here, we're looking at what normal levels are. So our sodium levels between 135 and 145 that occur 24 hours post prolonged physical activity. That's the user group. Dilution of sodium levels in the blood reach a critically low level, often by drinking too much water and not eating enough food. Now we can get into dehydrational hyponatremia. You can have hyponatremia and then cascade into heat stroke. We're going to keep them separated out for right now and talk about how to treat them. The little diagram in the corner, again, very simplified, but just to point out that the relationship between sodium and potassium, the sodium often living in that free space anyway, and as it becomes washed out of the body and moving around in the free space and diluted, it's going to lead to problems and issues. So we'll get into that. So here we are back at our heat triangle. Dehydration on the left side, not enough water, overuse and metabolic demand, just not stopping and resting, and then hyponatremia, not eating enough food, particularly salty food, and over drinking. So some common complaints or things we hear about, we've probably all experienced even in the hot climate: headache and dizziness. For our patients who are dehydrated, they're actually going to feel better lying down. There's not enough water, or the pump is not primed as well, so to speak. And they're going to do better if you lie them supine on the ground. It could be in a lateral position as well. And they're going to feel better, and maybe their symptoms will lessen just a little bit. Their dizziness isn't going to persist into a fainting cascade and have them fall over and hit their head. Our patients who are hyponatremic are going to actually, generally speaking, feel worse lying down. And if we think about this and the why, that little diagram, and I talked about flushing that sodium out. So we have too much water. Essentially, we filled up our GI tract, our gut, we filled up our vasculature, we filled up our interstitial spaces in the body. That water eventually down the road is going to be competing for space anywhere it can find in the body. One of the spaces that there's actually a little bit of room, not much, is in the cranial vault. So sharing and competing for space against the brain. So folks complaining of headache and dizziness who've had, in fact, too much water. And when we say too much, there's not a set prescription. It's different for everybody. It's hormone dependent. It has a lot of factors. You're going to see in a minute here, we'll talk about secreting and getting rid of water. But women tend to hang on to water a little bit easier than men. It's going to be your makeup of your body that day hormonally, other things that you've eaten. Have you had recent illness, kind of where your body is in its balance. So if we can't shed that water appropriately and it fills up those spaces, it's going to be pressing against the brain, making our headache and dizziness worse. So your patients that are constantly fidgeting and wanting to sit up, they're not comfortable in that lateral or supine position, you want to start to be suspicious. The nausea and vomiting, pretty straightforward and easy. We can understand that if they haven't had enough water and they're not properly hydrated, it's going to be a lot of bile content, dry heaves, food content. It's going to be pretty chunky. On the other end of the spectrum, if they have copious, clear, and projectile vomits, we go back again to thinking about that brain being pressed upon, and it's showing up like a head injury of sorts. So that pressure on the brain is causing that projectile vomiting. Not in all cases, and much of this is anecdotal over years of time here, over decades seeing patients at Grand Canyon. Some of the things that we look for in the field. Now we get into urine output, and most people know that if there's no urine output, or it is, we say, about 6 to 8 hours without output, it's dark, there's any kind of flank pain or kidney pain, then we are suspicious of dehydration and down the cascade of rhabdomyolysis. And we're going to touch on that in a few slides from now. Now, commonly understood also, if their urine output is copious, frequent, or they're experiencing bloating or retention, that all makes sense. What if I explained that they could have no urine output and still be on the right side of the spectrum, the hyponatremic end? So they've drank too much water, they didn't keep up with their salt, and they're not peeing. What's going on? Well, there's this thing in our body called, previously called antidiuretic hormone. Now it's referred to as AVP. So it's androgen vasopressin. I'm not sure if I said that right. I'll defer to the doctors in the group. And AVP is secreted and starts in the hypothalamus, cascades along, is secreted through the pituitary gland. Anytime our body is under stress, and a hot environment and a workload like hiking in and out of Grand Canyon is certainly a stress. Being on a search and rescue can certainly be a stress. You're thinking of multiple other things, and all your body knows is it's taking in inputs from the environment, that it's in a hot environment and it needs to retain water. So it's secreting this AVP at intervals or proportions that aren't letting the body urinate and let down that urine, and thus hanging on to water, and it really needs to be getting rid of it. So if we rest our patients, or we rest ourselves or our partners, our search partners, for 45 minutes or better, you should start to see the body self-regulate. That AVP is going to start to go away and that urine letdown is going to happen. And we have seen patients that self-correct over time. Here at Grand Canyon, we use iStats, and we're able to take a blood sample and assess where they are within 135 or 145 of normal sodium range. In our treatment protocols here, we give 3% hypertonic IV solution, 300 cc's over 10 minutes, 100 at a time. And we give that solution if the patient is 128 or less, because we've found that that's typically the seizure threshold, or if they are under 135 and symptomatic. And symptomatic would be altered mentation, a 1,000-yard stare. We'll get into that in a minute. So we're without those tools in the backcountry, or for some reason our tools aren't working, we can sit and rest and usually start to help correct that patient. It's not going to be large jumps in the sodium levels, but if we fluid restrict orally, don't give any IV, try and get salt back in the system and let them pee out, we can start on a road to recovery. Altered mentation, unconsciousness, posturing, and seizing. Again, you can see them on either side of the spectrum. If we look on the dehydrated side, fainting, again, not enough fluid, and sudden delirium. I can't stress enough when we talk to folks on the trail, companions, hiking partners, people that are around as bystanders, when someone collapses in heat stroke, this is something that folks talk about often, is the suddenness of it, that there weren't any signs or symptoms, the person otherwise seemed fine, and it was a very quick collapse and a very quick cascade through heat stroke into death. It's really been bystander intervention and people paying attention to one another, checking in frequently, and not being so bent on our ego that we can't ask for help. So it's really important that we constantly check the mentation. That, you know, is your hiking partner grumpier than normal? And if the answer is yes, you need a 45-minute timeout in the shade, and you need to start looking into that and doing an assessment. We don't want to mess around with this because it does happen so fast. If someone gets to seizure and coma in the field for heat stroke, it's really unlikely that we're able to recover them and bring them back from that compensation to decompensation. If a patient has hyponatremia and hits that seizure threshold, which is different for everyone, 128 and less is really the spot where we start to worry, but bodies vary. And so in the seizure end of things, hyponatremic patients, it's not good for them to stay in a seizure state or have multiple seizures, but they do, even after that, have very good outcomes. They are suffering from cerebral edema. They need to correct those sodium levels to adjust and get well again. But with our treatment protocols, we're now seeing people stay very short stays in the hospital. Sometimes they're in the morning and out that afternoon or evening. Sometimes it's a one-night stay, whereas historically, prior to our treatment protocols, we would expect them to wean that person up or titrate up their sodium levels and bring them up to normal again over the course of 4 to 6 days. Similarly, the altered mentation unconsciousness, the hyponatremic patients, we see a lot of anxiety, muscle fasciculations, 1,000-yard stare is really common. So you can engage them. They can answer all of your A&O questions. They might not appear altered, but they're going to have a change in their personality. And a change sometimes is, you know, my hiking companion never swears, and she's used this swear word 4 times today, and she's staring off into space and she's slow to respond. That is enough for us that we go ahead with treatment. So you want to dig into asking questions about your search subjects, what's normal, what's baseline, and keep a good eye on one another. If you're seeing any of these, you want to be suspect that they're somewhere on the spectrum, and the treatment, fortunately, is pretty much the same for both. So we want to stop exertion. We want to stop, for our dehydrated patients, that metabolic demand, and we want to start the body resting. For our hyponatremic patients, we want to stop that exertion and that stress that might be lending itself to secreting more antidiuretic hormone. We want to stop them from feeling like they need to drink more. So stopping. We want to initiate rapid cooling. I can't stress this enough. Rapid cooling. I have here an image of a guy in a makeshift tarp with an ice bath, and he's got some other monitoring devices on him. So this is clearly a laboratory setting. I apologize, I don't have one of our litter set up. We use it a couple times a year, and really the patients that have had their lives saved in the field isn't through us. It's through bystanders taking tepid water and recognizing the urgency, cooling this patient down. So part of rapid cooling is also getting this person stripped down as best as possible. So shoes come off, socks come off, constrictive clothing, pants, you're often down just to underwear, shorts, base layers, all of that needs to come off. And get them in a shaded area. Deep shade is best. That deep shade is an area that doesn't warm up during the day as much and stays cool or stays shaded throughout the day. If you can do an emergency drag or carry to a location like that, if all you have is another tarp or a means for makeshift shade, that is better than nothing. I'm going to guard against and protect against those UV and that direct sunlight. I've often suggested to folks that we think creatively about vessels. Our backpacks are not made to be buckets for carrying water, but they certainly will hold enough water for a short period of time that you can ferry water that way. I personally, if I'm on a search event and I know that I'm in radio contact and have good weather and every indication to believe that help is coming to my location, if I find the subject, then I'm going to go ahead and dispense everything that I can to soak this person down. And we're not just talking about, you know, a handkerchief to the back of the neck or just on the head. We are talking about cooling this person's core body down immediately. A side note, and why it doesn't matter if they're hyponatremic or dehydrated, rapid cooling either patient is critically important because you're dehydrated moving toward heat stroke patients are going to have their life saved from this intervention. Your hyponatremic patients are going to be uncomfortable. It's kind of like putting a cat in a bathtub. The reason for that is if we think back to that cascade of the sodium displacement or being flushed out of the body, that sodium helps to regulate our nervous system and our integumentary system being part of that as well. So sometimes we'll get reports of folks on the trail who complain of shivering and the air temp is 110 in the shade. Well, we know they're not cold. What's going on? It's a derangement of those electrolytes and it's giving false impulses to their brain about how their skin feels. And they will complain. They may even be actively shivering. Don't put them in a sleeping bag. Don't try and warm them up. You can, after you initiate rapid cooling, if they're altered, so that you know that heat stroke is no longer on the table. As I said earlier, you can have a patient that's hyponatremic and exertional and dies of heat stroke. So we want to make sure that's not a factor. Rapidly cooling them, getting all their clothes off, getting them into shade, getting whatever water that's available on their person. Sometimes we get the question, if I have very little water, should I drink my water or pour my water on my body? Your body's going to be better off if you drink your water. So if you're down to that little bit and you're trying to figure out which is better, it is better to drink the water. Step 4, monitoring inputs and outputs. Again, if they are dehydrated, you're going to want to give them what they can tolerate. When they're exerting themselves, here at Grand Canyon, we're hiking up many, many vertical feet. And altitude, our south rim is near 7,000 feet. Our north rim is near 9,000 feet. We're exerting ourselves in all sorts of hot temperatures, can be upward of 130 in the direct sun. I know Death Valley is breaking some records and that's pretty extreme. So letting the body rest is also going to shunt the blood that has been shunted from the GI and intestinal tract is going to start to come back into play. And they're going to be able to consume more. So if they're throwing up at first and you're just wetting their palate as you're doing this other cooling initiatives and they're not altered and they have a patent airway that you're not concerned about, work through that process and it's going to take some time. Let them start taking in oral fluids as tolerated. Outputs are going to be monitored in either case. If your patient is falling on the hyponatremic end of the spectrum and we're concerned that they've had too much to drink, you do want to fluid restrict them, take their hydration bladders away from them, take their water bottles away from them. I've had negotiations over literally capfuls of water before, because think about it, that the brain is being pressed upon and there's a bunch of other things going on. That thirst mechanism is broken, kind of what led them to over drinking in the first place. So if they're insistent and you can't do it any other way, you can let them have a cap full of water for a mouthful of, salty snacks. So a pretzel or whatever. Again, resting and letting that urine let down, we'll start to see them self-correct. Number 5, seeking medical care. Good assessments, finding out what they're drinking out of, how much they're drinking, how much they're eating. These might seem like really unimportant questions, but it will lead you to a pretty accurate field diagnosis of what's going on, and that can help you toward better treatment later on. The dehydrated patients at the upper levels, going to continue to rest, and fluid resuscitation, again, oral or IV, whatever is accessible, whatever is tolerated. Hyponatremic patients, we're going to continue to rest them, hoping for that urine output. We're going to fluid restrict, as I said. We've seen folks here at Grand Canyon misdiagnose and think, because again of that AVP hanging on to that urine, geez, my patient is down at the bottom of Grand Canyon on a river trip and they aren't peeing, and I'm going to give them IV fluids because I happen to have it. I have medical credentials that allow me to dispense it, and we've seen people made worse and put into that florid seizure or seizure state by having IV fluids administered when they were hyponatremic and not dehydrated. Fluid restriction until urine output, and then electrolyte evaluation, as I described, if you have access to it, and then electrolyte replacement, again, either oral or hypertonic IV solutions. Okay, we're gonna talk about rhabdomyolysis, otherwise known as rhabdo, next. So when we're talking about down that cascade of dehydration, heat stroke, and I mentioned earlier that flank pain assessment, if we're seeing flank pain with muscle cramping and disproportionate pain on palpation, so we can see a wide variety of muscle cramps. They can be in the lower extremities predominantly, in the calves and the thighs, in the stomach. And in some cases you can see from a distance, like a couple of yards away, you can see someone bent over their hiking poles and those large muscle groups in their thighs are just fasciculating or really twitching without the patient's control or ability to stop it. It can be quite painful. Again, some of it's the electrolyte derangement, some of it they don't fully understand the cascade of why, and in some cases the cramping sensation and the really painful cramping from rhabdo. When we would go to palpate a calf muscle, for instance, somebody's complaining of not being able to walk and their calf looks swollen, kind of waxy and taut, like their skin is really tight. And if you just lay your hand on their leg to palpate it, it's just the simple touch of putting your hand there causes them disproportionate pain, like 12 to 15 on the 1 to 10 scale. They might be screaming. They won't let you even touch them, that kind of disproportionate pain, coupled with dark or non-existent urine. Dark urine would be kind of tea or cola colored, feeling tired or weak. Again, that flank pain. And if you could get them to a point of care, there's no point of care field testing I'm aware of for this, so it would be an urgent care or above, and get their blood labs drawn and look at their CK levels. In the hundreds, up to 100 is in the hundreds is normal. It's varying for person to person and men and women, but we're talking in the thousands, 5,000. We've seen our clinic here break some records before. So we're really concerned about kidney function. Some patients have had to have a round of dialysis to support their kidneys while they're recovering from this. Other people have done more severe damage. In one case, I know a man who required from the compartment syndromes from this and that tissue breakdown, double fasciotomies, so medial and lateral on both legs. He had double fasciotomies with wound vacs and was hospitalized in the ICU for an extended period of time. This individual was out of shape and overextended himself on a backpacking trip with a lot of weight down the north side of the canyon. And unfortunately, the blood labs also showed amphetamines on board, which was concerning, but none of that was a recipe for a good trip. So when we show this slide, it's just a visualization and to help people understand better one's ability to compensate in the hot environment, or compensate at all for that matter. The blue squares in the center would represent the injury or illness of both patients. The patient on the left with the red box would be a 42-year-old female suffering also from hypertension, CAD, diabetes, obesity. The patient on the right would be a 42-year-old female suffering from the same injury or illness, but not having any of those things. She has a lot more free space to compensate and overcome that injury or illness. The patient on the left, in conjunction with those comorbidities, is likely taking medications to help manage those. And there's factors in with that around hydration and how that works in the body. So something to consider when we're thinking about risk factors for the hot environment. A lot of cases here at Grand Canyon, we see people are often asking, journalists in particular, what's the most or common injury or illness? And though orthopedic injuries and heat illness, but some of the factors around that are really people's core fitness. In the pandemic in particularly, we have lacked some of our collateral fitness. So if even we're keeping up a fitness routine that's the same, but we're not walking across large parking lots or in and out of box stores, up and down stairs, in and out of office buildings, we're missing some of that fitness there, and we may be overestimating our capabilities. We definitely see that in the canyon. Our visitation was down compared to the other parks in the agency last year by about 40%. We were up 30% in our search and rescues, and that had a lot to do with it. Other risk factors, when you're thinking about your search urgency forms, or you're thinking about folks in the field, we want to be particularly mindful of our elderly population. Again, there's not a set age. They say 65 here. This is from the CDC. It could be a 58-year-old with multiple comorbidities that's causing compensatory problems for them. Our young people, our kiddos, they have less ability to regulate those temperatures. They haven't dialed in their nervous system, whereas our older people are on the decline and are losing some of that function in their nervous system to self-regulate their body temperatures. And then also being able to stay hydrated, whether it's knowingly or internally, the body functions. Those are just a challenge in both of those subsets. Exertion in hot weather. I think I'd mentioned earlier in the slide presentation that in military training, participating in sports, football, we see it in CrossFit, and we see it a lot here at Grand Canyon, and not a lot. It's a regular thing. It's something we keep in our differentials, so we're concerned about rhabdo patients, but that exertional heat illness is very common here. I can't stress it enough. If you Google and look at running events and you're looking at hyponatremic runners and the electrolyte derangements, and it's kind of causing them to have rubbery legs, those are interesting to see the effects of. We unfortunately have seen runners that are otherwise very fit individuals succumb to heat stroke. So again, there's a wide spectrum there. The difference between being in Grand Canyon or being in one of your other national parks or in an austere environment is your access to care. If you are along a roadside, most generally you have quick access to an ambulance and a facility and a reputable emergency department in any large city, and you're going to get the care that you need. If you're in the austere environment having one of these emergencies, it's a completely different scenario. So I can't stress enough in the recreational settings that people need to be mindful of that and have contingency plans and not be tied to beating times and goals when things go wrong. That all goes out the window, and they have to sit in place and figure out how they're going to survive that environment. Same thing for our search settings. We have to be super mindful that we have been dropped off, or maybe it took us multiple days to get into our search segment. And here we are. And now we're having one of these emergencies. How are you going to take care of yourself? How are you going to take care of your partner in that environment? Sudden exposure to hot weather. A lot of times people visiting from other parts in the country think that May is a spring month and it should have spring-like weather, and that's not the case here. May and June are our hottest, driest months of the year. So anytime you're plucked from your normal environment and set down in a hot environment, particularly a hot, austere environment, you want to be mindful and have a plan on how you're going to manage that. Limit the activity for at least several days to allow yourself to acclimate to the change. The good news is that you can acclimatize to these environments, and we'll talk about that in a minute. Certain medications affecting one's ability to stay hydrated and respond to the heat. So how we metabolize our medications and how our medications, even though we took them, they might not be metabolized from an underhydrated body and thus not working for us and not functional. So our blood pressure could be out of regulation. Our other medications could be not as effective in the hot environments. Anything that causes vasoconstriction, regulates your blood pressure, or blocks adrenaline, such as beta blockers, we want to be mindful of. Anything that would rid your body of sodium or water, such as diuretics, is concerning. Alcohol consumption is often overlooked, so having a glass of wine with dinner, having a couple beers with dinner, that's going to affect your body's ability to compensate in this environment. Stimulants should go without say. Recreational drug use or amphetamines are concerning. And certain health conditions such as heart, lung disease, obesity, being sedentary, and having a history of previous heat stroke makes you predisposed to succumbing to it again in the future. So all good questions to know for yourself, for your team, and be mindful of when you're interviewing your search subjects. The preparedness piece. So we often say cotton kills, but not here in the desert. Cotton is our friend. It is moisture friendly. It hangs on to that moisture. It makes less work for our body in the evaporative cooling. You see Thomas and Lauren here hiking across the canyon in May for our team's orientation hike. And Thomas's headscarf, the shemagh that he's wearing, has dried out, but we usually will just dunk those in the creek and put them on our heads. We kind of want to walk around in a self-made swamp cooler. I can't stress enough. I have a pack of olives and Fritos. Fritos aren't my favorite. They're to pass out to the visitors. I have my own salty snacks. You really want to consider taking the things that you will eat when you don't feel well. When you're nauseous at home and you've got the stomach bug or you've got the flu, and when you can't really make it easily to the kitchen, what you know you'll eat, that's what you want to take with you. You want to test out your electrolytes ahead of time. You want to know that you actually like the flavor that you bought. You want to look very cautiously at what's in them and test them and make sure on shorter trips that is working for your body. There's not too much sugar. It's not making you nauseous, that type of stuff. We can't endorse any one particular product here at Grand Canyon, but there's just some stuff that's kind of a go-to thing for us. A pack such as the Hyperlite, there's several others on the market, but I can't stress enough. We go to high-end gear and we take gear for our team that will allow us the pack weight for water. So we want space and availability for that water weight. So we want to get high-end gear that'll allow us the ability to pack as much water as possible in certain environments. Down in the right-hand bottom corner with the electrolytes, there's an additional dromedary. You really want to think about durable. So a water bladder, that's great. I've had mine punctured by cactus spines. So thinking about these backup and contingency plans. There's weight to a Nalgene bottle or something similar, but what are you going to carry and what are you going to have as your main go-to and what could be your backup? Up in the upper right-hand corner, some extra headlamps and whatnot, but they're set on top of a tarp. And a tarp is just something, whether it's sitting down on the rocky, pokey environment and making yourself comfortable, it can be a makeshift shade shelter in a pinch. It can, as you saw in that other image, be a water bath. You can use it to haul water. You can certainly scoop up water with a tarp and haul it to where the subject might be. You can line a backpack with it and then use the backpack for hauling water. There's all sorts of creative ways that you can use these tools and figure out what works for you in the hot environment. But keeping shaded up is going to keep that skin looking young, keep you skin cancer free, and going to keep you happy and healthy out in the search area or on the trail. The good news I talked about is acclimatization. So like expanding your red blood cell count at altitude and being able to have more oxygen capacity for your body. Here in the hot environment, your body's going to learn to sweat smarter. It's going to increase its sweating efficiencies earlier on. It's going to start to hold on to the electrolytes. It's going to have sweat production earlier, and it's going to produce more evaporative cooling because you're going to sweat out more water and less electrolyte loss. Stabilization of circulation, the ability to perform work with lower core temperature and heart rate, that's always good news. Increased skin blood flow at a given core temperature. And then kind of some myth busting here at the bottom. It can often be regained in 2 to 3 days. So this is good news. These aren't myths, but they're to help dispel myths. We do lose it quickly. Your heat shock proteins, we'll talk in a minute, those will build up and they will go away pretty quickly, but you can return to work in a hot environment and build them up again quickly. It appears to be better maintained by those who are physically fit, which is understandable. Working in a hot, humid environment provides adaptive benefits, which also apply in hot desert environments and vice versa. Hot yoga people, I can't, there's my plug. I wish I lived closer to town. I'd go more often. Several of our rangers maintain their acclimatizations or try and keep up with their heat shock proteins in the wintertime and just make their body stressed in ways and uncomfortable in ways so that when they get back out into the field in the springtime and our temperatures are climbing up there, their body remembers how to do it. Air conditioning will not affect your acclimatization. So if you have these other things going for you, you still work out in the hot environment, you're physically fit, you watch out for those other risk factors, you have low more comorbidities, you can work an office job and go out and be an effective member of a search team and function, or a tech team, function out in these environments as long as you are keeping up with these other things. A couple folks here will pile on layers. You see it often in movies for boxers, but pile on layers and keep up with their heat acclimatization that way before they go out to recreate in the hot environment or do work. The heat shock proteins that I mentioned are triggered when the cells are under stress, and this cascade can happen in a number of different settings, but we're talking about it as it relates to heat. They will limit damage and facilitate recovery. So if you look at the little squiggly heat shock protein down there on the left, it goes through some heat stress, it will unravel, so to speak. And if it stays in that state and it cascades, it's not functional. It won't help your body with the bulleted list on the left of transportation, regulation, enzyme, structure, and signaling, which we can understand in thermoregulation, we can understand in electrolyte needs, and so on and so forth. So if they stay unraveled, we're going to lead to dysfunction. If you have your heat shock proteins up, it will process and repackage or refold those proteins to make them functional for all those things the body needs them for. Mitigations, as we think about our teams in the field, we're going to think about our heat thresholds or cutoffs. In talking with Anna, I know that there's certain searches, certain times of year at Joshua Tree where they just have a time of day. They build it into their IAP and they make it as part of their planning phases that they're not going to search on a particular day past a certain hour of the day when the temperatures reach and the UV reaches a certain threshold. Sharing pack loads, so maybe if you know that you have to go in for a particular thing, you're divvying up those litters, you're divvying up the gear loads or whatever needs to go in on that event amongst more people. Lowering their metabolic demands. And have smaller search segments. Think about this. I can't stress it enough for our plans and operations folks. When we are giving search assignments in these environments, we need to be really mindful. We have goals. We want to find those search subjects, but we have to be conservative about it based on what terrain and environments are out there for our team members. Cycling teams out more frequently. Medical monitoring, such as firefighter rehab. Snack and meal planning, this falls on us, on the individuals, but what's your backup? What do you know that you will eat when things are not looking good? Hydration strategy. There's some new, again, I mentioned this earlier, everybody's hormone level body size and body makeup is different. So there's still not good guidance on hydration. Dr. Myers will often say if you are 1.5 liters per hour or greater, you're falling on the overhydrated end of the spectrum. If you're 0.5 liters or less per hour, you're moving towards dehydration. But we have seen people fall all across that spectrum and do just fine. So it's not a set prescription. But Wilderness Medical Society and a team of doctors are coming out with what they're calling the hydration strategy. And so that we should see in 2023. And it, again, isn't going to be a set prescription that's a one size fits all, but it'll have some new guidance in there that's exciting. That's a crux here at Grand Canyon. People are constantly wanting to know how much they should drink. We can easily tell them that you should be doubling your calorie intake to get in and out of the canyon. That's kind of easy math. And it should be salty. It should be lightweight and easily digestible. But the hydration piece is a little bit more sticky. A couple quick case reviews that are points of interest, and we'll just run you through them. On June 6, 2021, about 14:20, a 76-year-old male, his weight was unknown. He was reportedly 4.5 miles down the steep, unshaded South Kaibab Trail. Environmental temperatures ranged because it gets hotter as you go down. So where he was, a shade temperature without shade of 103. So he was probably out in 115 to 120 degrees in the inner parts of the canyon and had come from the rim around high 80s, low 90s. The initial call was that there was a solo male hiker having difficulty ambulating, possibly a leg injury. He was possibly altered, possibly laying on the trail. We had a ranger who was already assisting another minor patient with a volunteer. She left that patient with the volunteer and she headed down trail. She stopped along the way and paused to refill her own water from an emergency water cache and brought additional water with her, which was an excellent move on her part. The patient was found alone, lying supine on the trail, diffuse sunburn. His skin was hot and dry to the touch. He had a rapid pulse and rapid respirations. His medical history was unknown. Bystander reported that the patient had possibly been unresponsive for 2 hours. His GCS of 3, his heart rate was 137. His BP was later, we were able to determine 135/91. There was some question around that. Rectal temperature of 105, SpO2 at 90%, and a BGL of 174. When this ranger did a quick assessment of his altered mentation and his skin temperature, just hot to the touch, she immediately dispensed multiple gallons that she'd brought with her and started evaporative cooling and called for air resources. They were able to bring an ice bath and do an ice bath trail side and then short haul this patient. So bringing him up to high altitude after being soaked in water. We'll sometimes, if we have to internally load him in the aircraft, we'll use a sheet that's been part of the ice bath, but we'll dump out all the content so it's not just flowing around on the floor of the aircraft. So those sheets are helpful. Brought up to altitude in a short haul Bowman bag and flown back to South Rim. That cools people off really quick. His mentation improved. He was about 5 days in hospital. He had some occupational or speech therapies for some slurred speech that he was suffering from post-incident. And to our knowledge, he received discharge to normal function, which was excellent outcomes, particularly how far down this individual was without bystanders. As I said earlier, a lot of these people's lives are being saved by bystander intervention. And he was a long way from any kind of water resource. It was only because this ranger brought additional water with her that she was able to save his life. A second case a little bit further back, May 5th, 2019. The call was earlier in the day and we were able to get on scene at 9:50. A 60-year-old male weighing 230 pounds. He was in the backcountry along the Colorado River, River Mile 135, if you guys are familiar with the Owl Eyes area along the river. The environment was 90 degrees. There were no clouds. The initial call came in by satellite phone call from a river trip to our dispatch center and then passed to our day's incident commander. When our aircraft and team got on scene, they found the patient lying on a sandy beach, moaning, exhibiting decorticate posturing. The center of his face was covered in blood. His nose was broken. He had multiple lacerations and injuries to his face. He was lying in his own feces. This individual had a GCS of 5, heart rate of 92. Blood pressure was unobtainable. His SpO2 was 86. His BGL was 22. His respiratory rate was 6 and labored, and his end tidal was 10. This patient was in really bad condition. Per the hiking companions who ended up on another beach and had to be rejoined with the group, they were hiking down a remote backcountry trail, the Bill Hall Trail, if any of you are familiar, Deer Creek, Thunder River area. 2 days prior, while hiking in, the patient was concerned about becoming dehydrated and drinking a lot of water, refusing to add electrolyte. By midday on the first day, the patient became delirious, per them. He took a fall from standing. His companions worried that without any way to contact help, they left the patient at the beach camp, hiked for help, where they found the river trip. And on the second morning, they lent their satellite phone to call for help. It was, I guess, too late in the night, the first night. The river trip took the 3 hiking companions and the patient across the river to a better landing zone. It was unclear why all 3 companions left the patient and did not return the next day. If they were having some of their own problems, it was unclear. The patient was noted to have more significant injuries than when they left him. The patient received IO, so interosseous access. He had oral suction, an NPA placed, an iGel placed, Versed, IV, dextrose, G50, evacuated with our aircraft to the North Rim, and then he had a HEMS to the St. George Hospital. So our first patient that we talked about, very classically heat stroke, still an older patient. So, but those conditions there in June were really prime for that. We weren't surprised that we had a call that week, and a good outcome. This patient, unfortunately, we were unable to obtain his outcome. What was determined by the medical providers on scene after working with the HEMS aircraft for a few minutes up at their makeshift landing zone where they passed off the patient, we believe that the patient started out 2 days prior in his trip on the one side of the spectrum, the far right, being hyponatremic, and that his ataxia and his uncoordination was from hyponatremia. We can't prove this. We believe he then was called in as a head injury by his friends because they were calling him delirious after he took a fall, and they had every right to be worried about his head injury, but we think that he was maybe exhibiting this delirious behavior from the hyponatremia. Once they left him on the beach, he probably hit that seizure threshold, and through that workload and then a number of other cascades, he lowered both his sugar and his electrolyte levels and moved to the other side of the spectrum in dehydration. We can lose far more in our diarrhea than we can, which is what he had, than just vomiting. And so he probably shifted, and we do see patients like this from one end of the spectrum to the other. So again, not to solve in the field, we want to first take away that threat of heat stroke and consider and move right to active cooling. And then we want to proceed with our other assessments, managing those airways and getting them to the next level of care. So really just points of interest so you guys could see what we deal with here at Grand Canyon. But I can't stress enough for you guys to stay safe out there, take good assessments, be cautious and conservative. And I hope this presentation gives you the tools to better assess your search subjects and keep yourself safe out in the austere, hot environments.
Hey, Megan, and I'll read out the questions for you.
Yeah, please, go ahead.
We have a lot of questions, so.
Oh, okay.
A lot of questions. If you are not able to make an electrolyte analysis, can you harm someone with hyponatremia by giving them Gatorade or electrolytes?
Not orally, not necessarily. I mean, they've already done most of the damage. What you're going to run into there in the later stages is that pressure buildup on their brain is going to hit a critical mass, and they're just not going to keep it down. We've had in our history here, 2, possibly 3 patients have died from hyponatremia, and we've had hundreds. So those are good numbers.
Got it.
You do want to fluid restrict, so fight that battle. Take their water bladder away from them. Don't let them drink more, but you're not going to kill them from that. They've already done that damage. And hopefully if you can get them to rest, that antidiuretic or that AVP is going to deplete, and then they're going to start to pee. And we've actually, it's uncomfortable, but I've coached altered patients that are ataxic into wetting themselves. We're trained not to do that, but if you can get them to pee themselves and stay in place, you can do a lot of recovery that way. Gets messy, but it's key.
Okay. Is there a rapid field test available for hyponatremia?
No, not at this time.
Do you recommend a specific electrolyte replacement?
I personally had norovirus compliments of the daycare in my 2-year-old in May, and I really liked the liquid IV.
Okay. Liquid IV, everybody. Wilderness medicine guidelines.
But I can't, as a government employee, I can't, suggest one brand over the other. There's lots of good stuff out there. Look at the magnesium, do a little bit of research, compare. You want low sugar. Don't go for the sugary stuff. That's not going to sit well.
Excellent. This question is a new question. Wilderness medicine guidelines from 2019 suggest highly concentrated replacement of 3 to 4 bouillon cubes in 125 milliliters or 1/2 cup of water.
Yeah, yuck. So that research came out of Grand Canyon, and that was in our protocols for a while. Just in the last, I would say 3 years or so, we've switched from the bouillon cubes because people throw that up so quickly. And we had enough experience of getting that thrown back up on us. Tastes bad. Now we switched to the ramen packets. So it's kind of funny. Our community kitchen here has a lot of plain ramen noodles with no seasoning packets because we buy them in bulk and we ship a good number of them down into the canyon, and we have people eat ramen bowlful after bowlful, and that's the oral replacement, and they really like it. If we're in the ambulance or on the go, you don't have the ability to sit and cook noodles, so we're giving them that 3 packets of the broth in a small volume of water and having them drink that, and that seems to be a little bit more palatable. It's really funny to watch somebody, they're scarfing down a bowl of ramen noodles and saying, I haven't eaten ramen since college and this is delicious. It's because their body craves that salt so much, and it really can turn things around. But yes, that is correct. We've switched from bouillon, though, to the seasoned packets for ramen.
And kind of a follow-on questions, any suggestions of snacks with electrolytes that are really effective?
Yeah, anything light that is airy and easy to digest. And I don't want to put down the sports bars because they can be packable and easy. You want to eat those before you feel sick and before you have an electrolyte derangement. Even trail mix, right? So the caloric intakes and outputs from nuts, it takes a long time for your body to break that down. Similarly, if you think about a dense a Cliff Bar, I'm just going to pick on them because they've been around a long time, and we get that is common language. That is really dense. Your body has to put a lot of fluid forward to digest that and break that down. So that is something that you have to be eating ahead of time, early on, or well hydrated to manage. Everything else, you want light and easily digestible, which is why we go with the salty snacks, pretzels, Pringles, Fritos, the Gardettos, that kind of stuff. So anything easily broken down. Another thing, when your body has worked and worked and worked, you've expended and exhausted all of that sympathetic, and now you're just living off the parasympathetic. You've shunted all the blood away from your intestines and your stomach, and you're not resting adequately. You do not feel like putting anything in your mouth. So if we can just get someone to suck the salt off of a pretzel, sit and rest, let that blood start to come back into circulation and into the GI tract and help things improve. Then they can go back to actually chewing and swallowing. Sometimes we've even met those patients where putting ODT Zofran to help them stop vomiting, but we just put that dissolvable tablet on their tongue. They're gonna throw that right back up at you as well. So really resting that GI tract and sitting and waiting sometimes is the only thing we can do.
Excellent. Where do muscle cramps fit into the signs and symptoms pyramid you presented on dehydration versus hyponatremia?
Good question. So they're at that low, they can be at the low end spectrum of dehydration, and cramps, depending on how they originate and what they're from, are not fully understood, but we've all experienced, like, someone can tell you I'm having muscle cramps. And then there are folks where you can see on the trail, I can walk up to them and from a distance, they're leaned over their hiking poles and you can see that muscle fasciculation from far away. And those cramps are really taking off in those large muscle groups and really debilitating that person. That's when I start to ask questions about their urine output. I'll palpate along their kidneys and I'll palpate down their legs. And if I'm getting any kidney pain, flank pain, disproportionate leg pain on light touch, I'm going to be suspicious of rhabdo. We have seen patients give themselves compartment syndrome and thus lead to fasciotomies that are on the other end of the spectrum that are hyponatremic. And that, again, it's that volume in the interstitial spaces and lots of complicated science that I don't fully understand on how they get there, but we have seen patients with really low sodiums that have really bad. I had a patient 5 years ago that had double fasciotomies on both legs. So inside and outside, medial lateral fasciotomies to both legs post hyponatremia. And he was altered and went into seizure status. And he was just over volume. Subsequently was also taking acid and on a fun guys trip, on a backpacking trip. So those things don't go well.
Type 2 fun, maybe? I don't know.
Yeah.
You're a search and rescue team, and it's pretty common people just have 1 or 2 ice packs among all the group, and they come upon a severe heat illness patient. Where would you place that 1 or 2 ice packs?
Yeah, in the groin and the armpits, but I can't stress more importantly is soaking them down. And sometimes we'll see people being really skimpy with a little bit of water to the head or the back of the neck. We're talking about full on water depletion. Now, my hope would be that if your team comes across somebody in that state, that they're in radio contact and they have access to hopefully an aircraft or an ATV or a vehicle to their location. So dispensing all of their water in that urgent circumstance to save a life. And this is a tough judgment call because I'm telling you guys to give up something that's there to protect you and save you. But if it were me and I knew that more water was coming and I had access to more for that immediate benefit to that patient, I would dump all of our water. I've encouraged folks to take their backpacks. They're not great water buckets or water vessels, but they can get from the spigot down the trail in a pinch and dump water out of their backpacks. So dispensing all the water you can and create evaporative cooling. So thinking about things like a folded tarp, if we have an extra one of those, is going to create a hard surface. A map, anything that you can to get air circulating with that water, stripping their clothes off and creating makeshift shade or getting them moved into deep shade.
Okay. And I don't know if you're familiar with this, but what do you think of the WHO oral hydration formula?
Oh, don't know it. Sorry.
Okay. Gatorade considered an isotonic instead of hypotonic and could potentially worsen hyponatremia. Have you heard that?
That hasn't been discussed, and Tom's pretty up on that stuff. The thing with Gatorade that I see more frequently, and I don't mean to pick on or favor brands, but that and Vitalite have a high sugar content. And so looking for it to replenish those electrolytes, people don't tolerate it on an upset stomach very well.
Okay. What kind of monitor defibrillators do you guys use in the Grand Canyon?
We're really lucky that we have the Life Pack 15 on all of our units and at all of our aid stations. So we have 4 ambulances, 1 aircraft, and 2 clinics, and they are all outfitted with the same Life Pack 15.
Okay. Do you guys ever take any defibrillation down trail?
Yes, but we do have just a standard AED, simply because that monitor, as you know, is really expensive, upward of $25,000 a piece, heavy, hard to get around. And we have had several trail code saves when we just take the AED from the trailhead and zip it down trail. And those cases are usually in the upper half mile to 3/4 mile sections. Anybody deeper than that, especially if they're comorbid and we're looking at really high heat indexes, they don't survive. But we've had some miraculous code saves, and I'm always really proud of the team when that happens with standard AED. Temperature control, so worrying about the battery and the gel pads at those extreme temperatures is why we don't keep any kind of AED posted on trail.
Got it. John Soul in Utah was one of the guys that advocated for this presentation, so he's got to be very happy. And his question is, I'm sitting in my SAR office and a SAR call comes in and it's a super hot day. What should I eat while grabbing my gear and driving to the scene to get my own body ready for the mission?
A good question, John. It's going to depend on you. Carving up is a thing, just like running or doing a fitness event. I will eat pasta leftovers in the fridge. I'll grab a sandwich. I will also try and grab things that for that first little bit that I know that if I bury it under my water bladder and my pack, I can get away with, like meats and cheeses and sandwiches and things like that, for the short term. And then you're kind of looking at ready-made meals and MREs after that. But what you can tolerate and what's going to give you the biggest bang for your buck, a bag of Fritos and some ramen noodles before you head out in the field. Again, keep in mind, if you're acclimatized, that's going to be less of a concern for you. So it's going to be more the calories and less the salt because your body is going to sweat smarter, we say.
Very good. What do the elite Grand Canyon National Park Rangers do to acclimatize in heat, aside from hot yoga?
Get out of the office. It's really important for our field staff to be here in early April. We, in the rest of the country, have the season of spring, in April. It's really short-lived here at Grand Canyon, more and more, and it dives right off into the hot summer season in May and June. So getting our staff here, getting them out on short hikes, getting them familiar with what's in our emergency caches, the lay of the land. By early May, we're doing a rim-to-rim hike over the course of 4 days, and I usually hope that it's hot because that's going to be a real test for them. And the pressure's not on. They're just learning the geography. They're learning the park. It's fun. It's a good team building experience, and it gets them out there. But my goal is acclimatization, and I'm really looking for what their heat stresses are doing, how they're packing. Are they overpacking? Do they have too much with them? Are they packing smart? Do they need a little course correction there and some help there? And then I'm using that to make determinations about putting them out into the field when we do have our multi-day events. We've been lucky this year. We've only had one multi-day event. It was on the North Rim.
Very good. WMS guidelines talk about cooling cheeks, palms, and soles rather than skin covering major vessels. What are your thoughts on that?
Yeah, science is, I'm not a doctor. I have not been in the predicament where I've had just a couple of ice packs and I've had to pick, and then I've had, the situation where I've been able to look back and say, oh, that was a poor choice. I have heard that taught before, and I'm aware that, yes, at the hands and feet, there's some benefit there, and I can't speak to it anecdotally from my experiences in the field. The lives that I've seen saved have been from bystanders taking their hat or whatever vessel they had. Sometimes it's those little foldable water troughs for a dog to drink out of, or them to wash their dishes in, pots and pans, and they're shuttling water from the tepid creek or the hot water pipeline, because in a lot of cases it's warm water that's been sitting in that line, or it warms up throughout the course of the day. And that's what they're using to ferry back and forth and dump over these subjects. They're being saved by bystanders who don't have this education and this training. So it really is early recognition and intervention that something's seriously wrong, and getting that person cooled with water. So I'm sorry I can't speak more in depth to that. I wish I had a more controlled environment where we could do that. And then we come along with buckets of ice, and they go into a tarp and a litter, and they get doused, and then they get flown.
Very good. Well, Megan, that concludes the questions we have here. I'm going to do a quick tactical pause and see if anybody wants to jump in. I have certainly seen a lot of appreciation expressed. This is a very well attended presentation, and I'm going to just throw my opinion out there that it's one of the better presentations we've had. Anybody else have anything to say?
Technical errors. I'm sorry I was late, you guys. Such an honor to be with you, and really intimidating to speak about the humid climate. I'm from Western New York. I know we have MRA groups across the country. I looked at the map. There's a lot of you that are in that wet blanket, hot kind of environment, and that's a whole different ball game. So I can't stress enough. Take care of yourselves. Look out from one another. Suspect early, and go into the field with a mindset that you might need to be intervened with, and you might need to be helped. And it's not a place for ego. If somebody says to you, "Hey man, I'm worried about you. You're not acting right. We got to take a time out," and they call it, I'm going to be proud of those crews. So look out for one another. I've had hyponatremia myself in the field, hiking into Havasu Falls on a personal trip. It's not pleasant, and any one of us can get there. I was living in Albuquerque at the time and not acclimatized. So get out there, recreate, look out for one another, and pack smart.
Thanks, Megan.